Então, vamos dar início a mais um grande round. Esse grande round ele é uma parceria da Diretoria de Ensino do Hospital de Clínicas de Porto Alegre com a Faculdade de Medicina da Universidade Federal do Rio Grande do Sul. Então, durante esse ano de 2025, vocês têm acompanhado que a gente tem grandes rounds destinados aos departamentos da Faculdade de Medicina. Então, hoje é o dia do departamento, meu departamento, né, o departamento de pediatria. Então, com imenso prazer, a gente vai ter uma convidada ilustre, né, a professora Anne Monique Nitt, ela que é Chief of the Department of Pediatrics da Faculdade de Medicina da Universidade de Montreal, em Quebec, e ela é Scientific Director da Canadian Research Network, onde ela se destina, né, a linha de trabalho dela é com prematuridade e DOHAD, né, que é o Development Origins of Cardiovascular Health and Disease. Coordenando, junto comigo, esse grande round, a gente vai ter a professora Rita de Cássia dos Santos Silveira, que é professora do Departamento de Pediatria, professora titular e também professora de Serviço de Neonatologia do HCPA. E, como debatedores, nós vamos ter a professora Valentina Chacre, que é chefe da Unidade de Pneumologia Infantil do HCPA e chefe do Departamento de Pediatria da Faculdade de Medicina, e a professora Fabrícia Sodero, que é professora, né, do Serviço de Pediatria e também do nosso departamento. O tema da professora foi muito bem pensado, né, a gente pensou com muito carinho, e é um tema muito pertinente, que é o segmento dos bebês de alto risco, né, focando na prematuridade e como os cuidados nesses primeiros anos de vida serão fundamentais para a qualidade de vida dessa criança na adolescência e na vida adulta. Professora Rita, por favor.
Obrigada, Leandro, pela amável introdução. Então, eu vou fazer uma breve introdução da nossa realidade aqui no HCPA, nessa questão, onde a gente vê a maior sobrevida de prematuros com menores idades gestacionais. E o que a gente percebe? Após essa longa jornada, quando chega o momento da tão esperada alta hospitalar, o que a gente tem que se questionar? Como melhorar os desfechos? O que a gente precisa fazer para garantir um cuidado na infância para prevenção de doença na vida adulta? Em cima desses conhecimentos, a gente tem montado há muitos anos estratégias assistenciais no HCPA, que são, sim, de caráter multiprofissional, lembrando sempre que o follow-up do prematuro é uma extensão do cuidado perinatal e ele não é puericultura. É necessário suporte à família, à criança, começa já no preparo para a alta hospitalar, porque são, sim, crianças com condições complexas crônicas e que terão um impacto mais adiante e que precisamos, sim, ter uma interface da internação com o segmento ambulatorial para garantir o não retorno ao hospital, para evitar futuras hospitalizações. Então, nesse aspecto, o Brasil caminha por uma questão complexa, que o primeiro mundo está um pouquinho à frente de nós, e a Anne depois vai trazer para nós, mas, de toda maneira, aqui no Hospital de Clínicas de Porto Alegre, nós temos trabalhado ativamente do ponto de vista multiprofissional, e eu vejo aqui no anfiteatro várias colegas que trabalham comigo, no caráter multiprofissional, para evitar no ambulatório o retorno ao hospital, ou tanto a UTI pediátrica quanto a enfermaria pediátrica. Isso passa por uma vigilância constante desses pacientes, buscando melhores desfechos para os nossos prematuros, e a rotina envolve toda a equipe. Nós temos diversas publicações mostrando isso. Aqui eu pautei apenas 3 delas, que envolvem fisioterapia, envolve a enfermagem e envolve a fonoaudiologia no impacto de um programa de nutrição, num feeding program, para evitar as aspirações, evitar a necessidade de via alternativa alimentar, como gastrostomia, por exemplo. Na fisioterapia, reduzir as restrições, prevenir doença metabólica óssea. E, na enfermagem, o carinho, o toque, um canguru plus, que a gente trabalhou num projeto super interessante, onde mostramos diversos desfechos favoráveis. Não podemos focar nas práticas exclusivas dentro da UTI neonatal. A gente tem que fazer a linha de cuidado do nosso prematuro, que, sim, começa no nascimento, continua durante a internação e segue no após a alta, com monitoramento cuidadoso de todos os aspectos do crescimento, desenvolvimento. Tem várias publicações internacionais mostrando que, para melhorar o neurodesenvolvimento, é importante, sim, a gente promover estímulos precoces. Tem uma revisão da Cochrane, com 25 ensaios clínicos randomizados, publicada há 3 anos atrás, que mostrou que a estimulação é efetiva em aspectos motores, mas os aspectos cognitivos eram pobremente avaliados, e, a partir daí, a gente montou um projeto. Aqui tem o QR Code desse projeto, quem está online também pode ter acesso, né, para que veja como que a gente desenvolveu essa intervenção aprimorada realizada pelos pais, e publicamos os outcomes, os desfechos curtos, no JAMA, ano passado, e agora a gente está trabalhando nos desfechos na idade escolar, que ainda não estão publicados. A gente publicou também essa semana, quando o Leandro falou em qualidade de vida, pensei, pena que eu não trouxe o artigo do Early Human, onde a gente mostrou, saiu ontem, antes de ontem, o quanto a qualidade de vida é inferior nos prematuros nossos em relação aos nossos pares a termo, mas esses são dados da idade escolar de 2008 a 2012. Eu quero ver se a gente consegue ver a qualidade de vida desse grupo estimulado, se, com o envolvimento dos pais, a gente não conseguiu melhorar isso. E isso é muito do que a gente vai falar hoje, do que eu estou falando agora, é salvando o futuro, melhorando a qualidade de vida desses pacientes e tudo que é o nosso compromisso de equidade, de advocacia por essas famílias. Esse é um compromisso ético de todos nós, e a gente sabe que os pais, envolvê-los no cuidado é fundamental. Os pais são facilitadores eficazes do desenvolvimento de seus bebês. Nós conseguimos provar isso nesse ensaio clínico randomizado, num desfecho de curto prazo, e eu vou dar spoiler para vocês, na idade escolar também se sustentou esse efeito, mas isso ainda não temos a publicação. Então, esses programas de estimulação precoce após a alta, eles começam desde a internação neonatal, continuam em casa, no primeiro ano, pela estímulos mais motores, e, no segundo ano, mais cognitivos, já organizando aquela mente agitada que o prematuro tem, né? O que a gente tem que pensar do nascimento de ontem ao adulto de hoje? O que a gente tem? Tem que estruturar segmento de alto risco, para evitar o retorno ao hospital, monitorar adequadamente crescimento e desenvolvimento, para reduzir a morbimortalidade das crianças nascidas prematuras. O diagnóstico de risco para morbidades auxilia na orientação da melhor estimulação que aquele paciente precisa, porque isso, gente, é uma nova linha, uma nova era na nossa pediatria. Ela chegou, não é mais a pediatria do futuro, é a pediatria de hoje. E isso precisa ser feito por todos nós. Compromisso ético de sobrevida com qualidade de vida, pensando no adulto que estamos trazendo para a sociedade, no adulto prematuro, que vai ser mais hipertenso, que vai ter mais morbidades e que vai precisar de mais cuidado. E essa é a equipe que a gente trabalha atualmente. Aqui tem médicos contratados, médicos residentes, equipe multiprofissional, porque isso, sim, eu garanto a todos vocês, não se constrói um cuidado centrado no paciente e na família sem uma equipe comprometida no dia a dia, firme aí com a gente. Que eu sempre sou muito grata da sorte que eu tive de encontrar pelo caminho muita gente boa disposta a abraçar essa causa, para que tenhamos desfechos como esse dos quadrigêmeos, que me autorizaram, tenho por escrito, por isso que eu trouxe, né? E eu brinco, porque era uma idade gestacional de 27 semanas, todos de extremo baixo peso, e, na última foto que eu tenho, que é com 5 aninhos de idade, quando a gente é obrigado a assistencialmente não seguir acompanhando, né? Estavam lá as meninas bem felizes e o menino com aquela cara tristonha, né? Porque elas enlouquecem ele. Então, só para descontrair um pouco, eu já encerrei por aqui. Essa era uma breve introdução da nosso trabalho, resumidamente, que a gente faz aqui, para chamar a nossa convidada especial, que já está nos aguardando online, a doutora Anne Monique Nui, uma parceira maravilhosa e que desenvolve um trabalho fantástico nessa questão dos desfechos futuros e do DORAD. Por favor, Anne, vamos lá.
So I start, I guess. So do you still want my presentation?
Yes, it's okay. Go ahead, please.
Okay. So hello, everyone. I'm sorry I don't see the whole room. Thank you for being there. And I'm sorry also that I don't speak Portuguese, even though a good part of my team is from Brazil. So it's my pleasure today to show to you some of the work we did since the beginning of my career, getting interested in the cardiovascular outcomes of young adults who were born very preterm. So the objective of my study are to describe the influence of preterm birth on the cardiovascular health in adulthood and explore some of the pathophysiological mechanisms underlying cardiovascular changes after preterm birth. And we will look also at some elements that we can do because I'm also a neonatologist already in the NICU. Well, we all know that about 10% of babies or children worldwide are born preterm and 1% very preterm. This number changes in different countries and where there are more socioeconomic disparities and difficulties, the rate of preterm birth increases. You all know that very well. And even within Canada, the regions where we have the First Nations, they have higher rates of prematurity than the more wealthy regions of the country. The survival of preterm born children has markedly increased since the 50s, where it was maybe 15% for 27-week babies. And this is the data from 2014 for all of Canada, but the number has not changed much since 10 years. But as you all know, in our neonatal intensive care units, survival of children born 26, 27, 28 weeks is above 90%. We have to all realize that neonatology is a young field because, for example, in 1967, which is, to my point of view, not that long ago, there was the first heart transplant, but also it was the first baby ventilators. So this is a young discipline. The challenge, therefore, now is not so much survival, but disease-free survival, as was well presented in the introduction, which I understand a little bit. And these are nice portraits done by photographs here in Quebec, who himself had a baby born prematurely. So he did all those portraits of children or young adults holding their own baby picture. And I think we all, as pediatricians, are very sensitive to this. So you all know as pediatricians that the third trimester, which is the time that preterm birth occurs, is really a critical period of development. We all know that for the lungs, of course. We know that for the eyes. We know that for the brain. But we also need to remember it's also very important, for example, for the heart and the vascular development. Cardiomyocytes develop, actively multiply until about term at 40 weeks. And therefore, if you're born at 29 weeks, one can postulate that there will be an impact on the cardiomyocyte proliferation or ultimate functioning. Same with the kidneys. We have active nephrogenesis until 32, 36 weeks. So we all know that with preterm birth comes very often disease condition before birth, preeclampsia, chorioamnionitis, and then after birth, being in a higher oxygen environment, maybe having an infection, having IV lines with intravenous nutrition, which is very pro-oxidant. All these elements could have an impact on all the organs. There are two ways of approaching the long-term consequences of very preterm birth and everything that's happening in the neonatal intensive care unit. First, there's maladaptation. So we all know, for example, that babies who are in utero with placental insufficiency, they will send oxygen and nutrient mostly to the brain, the heart, the adrenals to preserve their survival, and they will accumulate as much energy as they can whenever there is energy, which is probably why, even though this adaptative mechanism in utero allows them to survive, when they are born, if there are a lot of nutrient available, these children are high risk of obesity, because what was a good adaptation to keeping energy becomes maladaptive later in life. So this could be the same concept for cardiovascular consequences. The other possibility for long-term consequences of preterm birth is simply direct lesions, as we see in the lungs. The ventilation, the oxygen concentration directly damages the lungs. We also know this is the case for retinopathy of prematurity, for example. The higher PO2 directly impact the development of the endothelial cells, of the small vessels of the retina, which leads to arrest, progression, and then abnormal multiplication. What do we know about preterm birth and cardiovascular outcomes? Studies so far have shown that children and teens have higher systolic blood pressure on average, probably 5 millimeters of mercury, 2.5 millimeters of mercury for diastolic blood pressure. And overall, in the Scandinavian countries, they have population-wide data. And when they follow these individuals, the further they can go, which is now the mid-40s, there's a 50% increase in the risk of hypertension. And this increased risk driven by prematurity seems to be stronger in women. Other studies from the Scandinavian countries have shown that the risk of ischemic heart disease between the age of 30 and 43 is increased by 1.5 times. Obviously, the risk of heart disease between the age of 30 and 45 is extremely low. So it increases 1.5, but the overall number remains extremely low, fortunately so. And the same type of association is observed for the risk of stroke, which is also increased, and more so in the ones who were born the most prematurely, 1.4 times more for those below 32 weeks. One of the first studies that we did with my group is that we thought if they have higher rates of hypertension, and they're still relatively young for us to totally evaluate what is the risk of cardiovascular disease later in life, maybe we could look at pregnancy, because pregnancy is considered an open window to future cardiovascular and metabolic health. So we thought, if preterm birth is associated with higher blood pressure and maybe cardiovascular disease later in life, what is the impact of preterm birth on pregnancy complications such as gestational hypertension, diabetes, and preeclampsia? So we were able to obtain funding to examine all the population of Quebec, that all individuals in my province here in Canada, which is called Quebec, who were born between 1976 and 1994, who were born preterm. And we matched them for each preterm with 2 individuals born term around the same years. And we examined, these were obviously women, and we examined what happened when themselves became pregnant. So the oldest ones in this study were 32 years of age, in fact. So the dark blue bars are the women themselves born less than 32 weeks. The lighter blue bars are the women themselves born 32 to 36 weeks. And the white bars are the women born term. And you can clearly see to the left that gestational diabetes is significantly higher in those who were born less than 32 weeks. And there's the lower the gestation, the higher the risk. This trend was significant. We also have higher gestational hypertension and preeclampsia. And overall, there's a higher proportion of women born preterm versus term who were diagnosed with at least one pregnancy complication at least once. So if a woman has 4 pregnancies and 4 times she has gestational diabetes, she's counted as 1. So overall, 20% of the women born less than 32 weeks had at least one complication at least once, versus close to 12% in those born term. So obviously, those born term, we all know that are not, they do have pregnancy complications. Another interesting thing that we found with this study is that women who were themselves born preterm have a significantly higher risk of delivering preterm, even if we take into account preeclampsia and other pregnancy complications. So 2.4% of the women born less than 32 weeks delivered them at less than 32 weeks versus 1.2% of the term, so twice as much. And similarly, any preterm delivery occurred in 14% of the women themselves born preterm, very preterm, versus 9.7%, which is the regular rate of preterm birth in the population. So let's explore a little bit studies that we did to examine mechanisms for cardiovascular outcome. So in order to have more detailed phenotype of what is going on in young adults born preterm, we launched Dr. Thuy Mai Lu and myself the HAPPY study, which stands for Health of Adults Born Preterm Investigation. So we contacted individuals who were born mostly at our hospital, but also other hospitals in our province of Quebec. We recruited 101 of them, and we asked them to come for a full day visit with a brother, a sibling, a cousin, or a friend who was same sex, same race, and born around the same years. And that allowed us, in fact, to have that the term group was very similar with the preterm group in terms of education level, socioeconomic outcome, and life habits. So if one was smoking, very high chance that the friend is smoking also. If one was doing a lot of sports, very high chance that the control was also doing a lot of sports. So this allowed us really to isolate the effect of prematurity in our assessment. As you can see, the preterm group was born at 27 weeks. They were weighing 920 grams. 90% of them were Caucasians because this was the population in our hospital in the mid-80s. They were on average smaller and lighter, but their body mass index was the same, and 20% of the whole group was smoking. So we assessed many things, as I said. So this is a busy slide, but I'll take you through it. On the left, you can see that we found that stage 1 and more hypertension, so any significantly elevated blood pressure, we found that in 39% of the individuals born preterm versus 18% of those born term. Glucose intolerance, we did oral glucose tolerance tests, was present in 31% of those born preterm versus 16% of those born term, and airflow limitation in 40%. We did pulmonary function tests instead of those born term, which was 16%. Overall, that's the middle graphic with the blue and dashed green lines. We can see that 38% of individuals born preterm in our cohort had 2 and more cardiovascular diseases risk factor versus 22% of the term for an adjusted odds ratio of 3.3. What was interesting, however, that we found is that, you know, in the general population, when one has hypertension, odds are this is also the person who will have glucose intolerance or obesity. But in the preterm group, we did not find this association. So hypertension was not necessarily significantly associated with adiposity or glucose intolerance, which might suggest that this is a different pathway of disease to hypertension versus the term population. We also examined whether there was biomarkers of inflammation or oxidative stress, which is, as you know, in the general population, cardiovascular and cardiometabolic diseases are associated with markers of chronic low-level inflammation and markers of oxidative stress. And our hypothesis, in fact, was that we would find higher levels of markers of inflammation and oxidative stress in the individuals born preterm, especially when we think what happened in the neonatal intensive care unit, and that they have higher risk factors for cardiovascular diseases. But to our surprise, we did not find any difference, and we did a lot of different markers, and we did not see any difference. So the first conclusion that we can see is that they have a significantly higher blood pressure, they have high rates of glucose intolerance and airflow limitation, but no, we did not find in our cohort differences in the hypercholesterolemia or any lipids, and we did not find, in fact, metabolic syndrome, because metabolic syndrome is the association of adiposity, dyslipidemia, diabetes, and hypertension. So as I said, we did not find that this was systematically associated. And in fact, not many papers have looked at that. They've looked at the incidence of all those things, but didn't look at whether it was associated in the same individual. So I will take you now to examine some of the studies there is about cardiac and vascular specific characteristics after preterm birth. So you probably all know this very nice studies that Adam Lewandowski and his group with Paul Leeson published out of Oxford. They did cardiac magnetic resonance studies on young adults born preterm, a bit older than ours. They were born at 30 weeks. Ours were 27 weeks with an average birth weight of 1,300 grams. What they saw was the left ventricle, the preterm are in blue here, was a bit thicker, had a greater mass, and had a different 3D geometry. So it was a bit thicker and a bit smaller. The total tissue was a bit smaller. They had a maintained systolic function, but a bit of a reduced diastolic function. So like if there was stiffness, difficulty to relax the left ventricle. And what was interesting also is that even when they corrected for the high blood pressure, the difference was maintained. We found in our, I'm not showing here because it doesn't add much, but in our population, we found similar things, except the mass was not increased. And our population was 27 weeks. So they were born sooner in the hyperplasic phase of the cardiomyocyte. So we can only postulate that the cardiomyocyte endowment, the pool of cardiomyocyte for the heart, might be a bit different, might be lower, which might explain why the thickness of the muscle was not increased in our group. Just to share with you some very interesting studies that have already been published, again, out of the Scandinavian countries. This study examined the rates of heart failure diagnosis in their administrative database, and they excluded all children with congenital cardiac malformation. And what you can see is that the children born prematurely, especially those born less than 28 weeks, which is the bottom red bar, were significantly overrepresented among those who develop heart failure. And we don't think children develop heart failure because of hypertension. That's not the cause. In general, heart failure in children is linked to virus infection. So is there an increased susceptibility, vulnerability to stressors such as myocarditis later in life? This is a postulate, but we don't know so far. Another interesting study that was published again by the group in Oxford is the left ventricular function in response to exercise. So the preterm are here in red and the term are in blue. And as they increase the exercise intensity, we can see that preterm young adults had impaired left ventricular response to the physiological stress, which was they were able to mount their left ventricular response, but they were not able then to continue to keep it high as the intensity of the exercise increased, which suggests a reduced myocardial functional reserve. To examine this question of susceptibility to stressors, I'm briefly showing you here a study we did in our animal model, and we decided to examine mitochondria because you know mitochondria is a powerhouse and especially important in the heart because the heart has to have a lot of energy all the time, obviously, to pump. We know that in adults with cardiovascular diseases, general population adults, myocardium remodeling, as well as cardiomyocyte hypertrophy growth and fibrosis are linked to mitochondria function or dysfunction, and heart failure is really related to mitochondrial failure to continue producing energy. We also know that at birth, as pediatricians, we all know that there's a sudden change in the physiology because in utero, both right and left ventricle share the work equally. And overall, the systemic system has very low resistance because we have the placenta. At birth, what happens? We cut away the placenta. The right ventricle takes care of the lungs, the resistance of the lung decrease markedly, and the left ventricle is faced with systemic resistance, which is much higher than it used to be. So it has to transition to a very efficient mode of energy production soon after birth to be able to keep up with the changing demand. This process occurs prematurely, by definition, in the preterm infant, so that the switch from glycolysis to oxidative phosphorylation must occur at a time that the whole cardiac machinery is not absolutely ready. So our question in our animal model is what happens to the cardiac mitochondria sometimes after this neonatal insult. So we don't have rats who are born preterm, but what we study are newborn rats, term newborn rats, but we know that their developmental stage for the eyes, the lungs, the kidneys, even the heart, is very similar about to a 27 to 30 weeks gestation infant. So there's still nephrogenesis, there's still proliferation of cardiomyocyte. So we expose the rats to 80% oxygen. So in a way, we reproduce this overflow of oxygen because of hyperoxic stress. And this model, we all know, is used to study retinopathy of prematurity and bronchopulmonary dysplasia. So we used it to look at cardiovascular outcome. We've shown in the past that these rats, they develop higher blood pressure, but even before developing higher blood pressure, their heart shows hypertrophy and fibrosis. And we also know that as adults, this is Mariani Bertagnoli, who came from Belo Horizonte, has showed they develop dilated heart failure when they are subjected to a second hit, which in our experimental model was raising blood pressure with a low-dose infusion of angiotensin II. So we decided to study these animals before their blood pressure goes up, when they were just after weaning, so like teenagers, and to look at the mitochondria in their heart. And what we saw was that on electron microscopy with the little black arrows, the mitochondria are really disrupted. The cristae are different. You can see that the fibers are not well aligned. This is a study by Daniela Dartora, who was postdoc in the lab. There's reduced oxidative phosphorylation, but increased evidence of glycolysis. So as if there was an impaired switch that had occurred. They had lower mitochondria content. As I said, mitochondria are disrupted. And there's even signs of lipid deposition, which goes with impaired metabolism. Obviously, we don't have the opportunity to look at mitochondria in the heart of individuals born preterm. But what we did measure is humanin. Humanin is a mitochondria-derived peptide, which is considered mitoprotective, in fact. So in our happy cohort, we measured humanin, and we found that in the preterm group, the blue box, it was slightly but significantly lower levels of circulating humanin. And what was very interesting is that for both preterm and term, humanin levels correlated with left ventricular function. So the higher the humanin levels, the higher the left ventricular ejection fraction and peak global longitudinal strain, which are the two bottom right panels. Regarding vascular health, you will recognize Rafael Fernandez, who is making the link between you and our team here. He contributed with Adrien Flao to study the vascular tree of our cohort, happy cohort. And in this slide, we summarize our finding and the finding of the Oxford group. Overall, what we see is that the aorta is a bit smaller. There's a reduced distensibility, so increased stiffness of the brachial and the carotid artery, which are two large arteries. But when we measure the global arterial stiffness, so including the small arteries, we don't see a difference. And we don't see a difference in endothelial function, which also was very surprising because classically, hypertension is associated with impaired endothelial function with reduced level of NO release, which is not what we found. And as I said, we're not the only ones who found it. So there's something going on with the structure of the vascular tree, but not necessarily the function in terms of endothelium at this stage in young adults born preterm. Interestingly, the Oxford group has measured pro and anti-angiogenic factors in their cohort of young adults born preterm. And what they saw, this is the bottom right histograms, is that soluble endoglin and sFlt1, which are two anti-angiogenic factors, the higher they were, the higher the systolic blood pressure. They also measured capillary density in these individuals, which can be measured on the finger and the ungual bed. And they saw that in preterm young adults, the blue boxes, they had lower capillary density and higher circulating anti-angiogenic factors, and they were able to show that capillary density was correlated with systolic blood pressure. In our cohort, we did not find differences in the levels of soluble endoglin, sFlt1, nor capillary density, but it makes, I think that pathophysiologically, the question remains very relevant and needs certainly further study. A word about the kidneys. In our study, we did measure initially kidneys by ultrasound. We just finished examining kidneys by MRI. I don't have those final results, but I'll share with you the ultrasound results. And what we saw was, you remember that I showed you the body surface area of the individual born preterm. On the right column was lower, but their kidney volume, the bottom line, was on average, even when corrected for body surface area, was smaller in preterm than in term. So their kidneys are smaller than themselves are smaller. What was interesting is that we did not see any difference in the glomerular filtration rate when estimated with creatinine-based equations, but we did have a little bit more microalbuminuria, even though this was not pathological level at all. But when you think that when you have smaller kidneys, but a normal GFR, this means that each cubic centimeter of kidney does a bigger job. This suggests glomerular hyperfiltration, which is a pre-step to compensate a lower kidney capacity and is a risk factor also to chronic kidney disease. This is something that we've assessed recently, and it would be a pleasure maybe in a year to come back and show you those results. Interestingly, this is the right graph. We did find a correlation between blood pressure and kidney size. So the smaller the kidney volume, the higher the blood pressure in individuals born preterm, but not in the term. I will try to speed up. We also, in fact, Rafael Fernandez noticed that the average hemoglobin of the preterm group was higher. So we thought it's interesting to look at erythropoiesis in this group, because we all know that preterm neonates end up with lower hemoglobin level because of erythropoietin deficiency, blood loss, blood sampling, and inflammation. We also know that adults born preterm have chronic respiratory dysfunction, which is worse in those who had bronchopulmonary dysplasia, which could be triggering maybe some mild hypoxia, which nobody showed, but it's a possibility. And we also know that hemoglobin levels in adults correlate to blood pressure. So the higher the blood pressure, the higher the hemoglobin, the higher the blood pressure. So as I just alluded to, we found in our cohort that both males and females born preterm, the blue square, the blue boxes, have higher hemoglobin. But what was very surprising is that they don't have differences in erythropoietin, which means, in fact, that it was like a shift. So hemoglobin levels are higher, but erythropoietin levels are lower than expected. So for a given EPO value, the predicted hemoglobin levels in preterm is 7.2 gram per liter higher, which might suggest disruptions in the erythropoiesis regulations. For a given erythropoietin, they produce more hemoglobin. Anyway, we haven't sorted this out, but we thought this was really interesting. What was also interesting is that the hemoglobin level in the adults was not associated with lower gestational age, but it was associated with longer duration of oxygen and with the number of red blood cell transfusion that each one had received. Obviously, in the late 80s, early 90s, we were giving a lot more transfusion than nowadays. We believed that transfusion would help oxygen transport and will help the lung disease. So it's hard to disentangle oxygen supplementation from red blood cell transfusion. Nevertheless, it's an interesting observation. And as we all know, when we transfuse babies, we transfuse adult hemoglobin, which has a different affinity for oxygen. So we might then disrupt the overall concentration of oxygen there is in the blood of those infants. So this is an open field for further research. What we also did see was through mediation analysis was that preterm birth leads to higher hemoglobin. Higher hemoglobin is associated with higher blood pressure, and the overall 37% of the effect of preterm birth on blood pressure was mediated by their higher hemoglobin level. But this is just mediation analysis. A few words about the muscles. Why look at skeletal muscles? You know that exercise capacity is really the marker of cardiovascular health. Exercise capacity depends on your lungs, which we may think are affected in adults born preterm, depends on the heart, which we've seen might be a bit affected in adults born preterm, but also depends on the muscles. And therefore, we thought, is it possible that the skeletal muscles might be impacted by preterm delivery? It is in theory possible because, again, third trimester is really an important moment for maturation of the skeletal muscle and the determination of the ratio of type 1 and type 2 fiber, which are slow or resistant fiber. There's a few studies that suggest, indeed, that preterm-born children and adults have a reduced exercise capacity, which could be in part explained by cardiopulmonary impairment, but not only. It could also be related to muscle capacity. So in our cohort, in a subgroup, we did ultrasound of the thigh, of the leg extensor muscle, the rectus, the femoral muscle, and the quadriceps, that's the word. And we also did, so we measured the size, the cross-sectional area, and we also did shear wave elastography, which is a reflection a little bit of the stiffness or the fibrosis, maybe, of the muscle. And interestingly, you can see, again, preterm are in blue, that overall leg extensor strength on the left panel is lower, and it's really correlated with the cross-sectional area of the muscle. But the correlation between the area and the leg extensor strength is about the same for preterm and term. And what was also interesting is that there is also a correlation between the leg extensor strength and the shear wave velocity, which might indicate that the lower the strength, the higher there can be stiffness or maybe fibrosis in these muscles. And here the correlation, the association was significant for term and preterm, but we can see that the slopes are not situated at the same place. So in summary, I've shown you very briefly that preterm birth occurs at a very critical period of development for many organs. In young adulthood, what do we see? Increased blood pressure. We have vascular tree changes. I didn't show you, but we've seen also that endothelial progenitor cells called endothelial colony-forming cells, their function is also decreased. We're currently examine this a bit further to see if they have an impaired capacity to develop new vessels or repair their vessels when there is an injury. The literature, as well as our study, shows that they have increased heart rate, which may be indication of higher sympathetic activity. The left ventricular cavity is somewhat smaller. There's some diastolic dysfunction. And there's also impact on the right ventricle function. I did show you data on that. Caragos out of Texas is doing a lot of studies there. In our cohort, we did not see differences in adiposity. So body mass index was not different. We did not see changes in the lipids, but other groups did find changes in the lipid profile of the adults born preterm. Everybody finds some degree of glucose intolerance and insulin resistance and lower fitness with decreased muscle capacity. But as I said, it is not the classical metabolic syndrome. This is important to address because of the graph I'm showing you. This was written thinking about the lungs. We know that the early 20s is the peak of lung function that one will attain in their lifetime, and then there's a normal decline in lung function with life. In preterm-born individuals, there might be a reduced peak of lung function, especially in those who had bronchopulmonary dysplasia when they were in the neonatal intensive care unit. Then if their later life normal decline is at the same rate, they will automatically reach symptoms of chronic diseases sooner in their life than the ones born term. What would be not good at all is that if in addition we have accelerated decline, so that's why prevention becomes extremely important. especially for things such as smoking. I think it's very reasonable to postulate that what we postulate here for the lungs can apply to many organs. Good things to finish for us pediatricians and neonatologists. This is again a study that was done by Adam Lewandowski from the Oxford group. He took advantage of the fact that in London, Professor Lucas had done in the late 80s, early 90s, a study where they were studying nutrition. They randomized preterm babies whose mother could not breastfeed, either to formula or to banked human milk, and to see how the growth was going. So they traced back those children who were not teenagers, and they compared the premature babies who had been randomized to formula, which are the blue ones, with the preterm babies who had been randomized to banked human milk, to a term-born group of teenagers. What they saw was the ones who had received human milk had lower blood pressure, and the shape of their left ventricle was more similar to the shape of the left ventricle of term-born individuals compared to the preterm who had been fed formula. So us neonatologists, we know human milk is important, is good, so that is something that we can really do not only for short-term complications, but for long-term positive benefits. Another thing that we did was we tried exercise. So we discussed with our participants from the HAPPY study, and we said, what do you think if we do a study to try which medication is the best for your hypertension? They said, no, we don't want to have any medication trial made on us. We first want to see if by changing life habits, we can improve our health. And this is a very good question, but because we can, obviously exercise is good for everyone, but what if the changes we see in their cardiovascular system, in their muscles, in their heart, in their lungs, is somewhat fixed because of the direct lesions there was during development. So it's an important question to ask. What can we gain with exercise training in this population? So we did a study of 14 weeks of exercise training, 3 times per week. 2 times they had to come to the gym with the group sessions, with the supervision of a trainer. They had to do 1 training session at home. We did a full workout before and after. It was a difficult study to conduct because you can imagine there was a lot of dropouts, and then COVID occurred. Anyway, we did manage to have some interesting results. These are published in 2023, and we saw that in the subgroup who did 70% of the training sessions, we did have a significant improvement in their VO2 peak, which is measures of cardiopulmonary capacity. In the term, for sure, this means our intervention worked, but we were very pleased to see this was the case as well in the preterm in blue. The other thing that we found, that in the subgroup of participants who completed the 70% of the full training and had high blood pressure to start with, in the term individuals who had high blood pressure, exercise did not change blood pressure, but in the preterm, there was a significant reduction in the 24-hour blood pressure monitoring. We took the daytime part for systolic and diastolic blood pressure. Small study, small numbers, is just encouraging to pursue this hypothetic avenue. I don't know in Brazil, but in Canada and in the United States, for what I know, preterm birth is not yet identified as a condition for targeted cardiovascular risk screening. I think it should be. We should be aware that they need to be monitored, especially young women when they will become pregnant. So my key messages are, in conclusion, was that preterm birth occurs at a critical period of organ development. Preterm birth is associated with an increased risk of chronic health diseases. But we think that using a life course approach Us pediatricians, we are well positioned to change positively the health trajectory of individuals born preterm. We need to make sure they have access to healthcare. We need to ensure better awareness for enhanced health monitoring of the preterm population, both the healthcare providers, but also the families and the young persons themselves, to allow earlier identification of risk factors that we can prevent and intervene early, such as exercise and smoking. So these are some of the participants of our HAPPY study. We are extremely grateful to them. You can see in front of you psychologists, NICU nurses, doctors, translators, social workers. So we're very humbled by their resilience and their participation in our study, and grateful. And this is our team. This was last Christmas, and I want to thank also all my collaborations that I have in Brazil and through Robson Santos mainly, but through all of you and the funding organization. So I will stop sharing. Where do I do this? I don't know if there are questions.
Dr. Nui, we would like to thank you for the great lecture with the most current information on this subject that is so important for our kids and our adults, as well, as you could see here. We have a few minutes for interaction with our audience. I don't know if anyone here has any question to Dr. Nui. If not, I'm going to ask you, you talked about angiogenic factors and capillary density previously on your slide, and I would like to ask you about the consequences of this phenomena on early vascular disease regarding pulmonary vascular disease that in their most severe form can lead to pulmonary hypertension.
You know, that's a very interesting study, and I'm not sure this was even looked at. So pulmonary hypertension, as you know, is difficult to measure. We did see changes in the TAPSE, which is a very indirect measure of higher pulmonary resistance. And we did not correlate that with our angiogenic markers, but this is a great idea that I can look and will be sharing results with you. And also, I wonder if Karagos, who does a lot of those right ventricle and pulmonary hypertension studies, has examined this. Thank you for this great suggestion. Yeah.
Hi, congratulations for the beautiful presentations and for Dr. Rita too. And I would like to ask, how early do you start the metabolic syndrome screening? How early we think?
So we are not systematically screening yet. As I said, it's not yet recommended by the pediatric or family physician societies. I think young adulthood would be a good start. I'm not sure we need to do that too early in childhood, maybe teenagers, because it's been reported already in teenagers that there's glucose resistance. And obviously, if there are some groups that will develop adiposity, is this an additional risk factor for glucose intolerance? That might be. It's very possible. It's hard because we don't have that large cohort studies examining this, because the administrative database that we have They don't report glucose intolerance. They report diabetes. In a way, it's too late. So I don't have the data to be able to tell you when we should start screening. But I think for sure these teenagers and young adults, when they leave the pediatrician office, should not be just let go in the nature, and they should be informed. And they told us, we want to be informed, and we want our family physician to be informed that we need extra monitoring of our health. That's what they told us. So at least regular visits.
Parabéns para ambas palestrantes, ótima palestra. Que ela teria alguma coisa para sugerir da toxicidade do oxigênio durante o cuidado dos prematuros para prevenir essas lesões futuras no coração, principalmente?
Based on the slide where you talked about the high flow oxygen and the high levels of oxygen that can impact on the function of myocardial, for example, one of our physicians here, Dr. Thais from the intensive care unit, is asking if you have any recommendation regarding the level of oxygen that we deliver to the babies during the care at neonatal intensive care unit.
The answer is no. Because we all remember the STOP ROP study, which the hypothesis was that if saturation is lower, so babies receive less oxygen, there will be less ROP. And it was true. The babies randomized to lower saturation had lower ROP. But there was a higher mortality in that group. And the study could not establish why. So even if physiologically it's logical for us to think that limiting hyperoxia for sure, but lowering our limits of saturation and therefore the oxygen we give to the babies is logical to prevent certain complications. But clinically, we cannot recommend this right now, because of the studies I just alluded to. We always have to think, what are the unintended consequences of this type of action? But limiting hyperoxygenation, limiting large fluctuation in the oxygen level and the saturation level, because that's what we have to measure oxygen, I think certainly this is a good thing.
Like to finish our session today with a question regarding your last publication. Of course, today the focus were on problems related to cardiovascular disease, but also we know that the consequences of preterm birth, they are also seen regarding neuropsychiatry diseases. And I would like to ask you to talk a little about the educational consequences of preterm birth.
Yes, you're right. There was a paper that our group just published. The main author wasn't me, so I'm not as comfortable with all the details of this very recent study. Overall, for the educational level, what we were very happy to see was that prematurity did not impact educational levels, except for the very preterm ones, those with, we all know them, the 27 weeks and less. For all the other ones, the main factor for educational achievement was the family, which I found in a way was a very good news.
like to thank you again for your presence here. It was great to hear you. And we are now finishing our session. I don't know if Professor Leandro... And sorry for not presenting me. I'm Professor Valentina. I'm a pediatric pulmonologist here at our hospital. And we hope to hear from you soon in future sessions. Thank you.
Yes, with pleasure. I should be visiting then one day. Thank you so much. Have a good day, everyone. Bye-bye.
We are extremely grateful for your participation in our hospital grand round. Thank you very much.
It was really my pleasure. I owe Brazil a lot of work that was done, so thank you very much. It's always a pleasure to discuss with you.
E agradeço a presença de todos e todas nesse nosso grande round. Espero que tenham aproveitado. Obrigado.
Thank you. Have a good day. Bye.